Hello, everyone. Thank you so much for joining us on our ORNAC National Conference Week. We're joining you virtually from Calgary. So really thrilled to have everybody join us this evening. It is ORNAO's pleasure to have sponsorship via Intuitive. We have Samantha Tennis on the line who will do an introduction to both of our wonderful speakers. We're really looking forward to hearing about your adventures and how to navigate robotics in the operating room. Thank you so much for your expertise in advance, Maria and Michelle. At this time, I'd like to hand it over to Samantha to do a brief intro, and then we'll follow with the presentation for tonight. Thank you and enjoy.
Hello, everyone, and welcome. We're so glad you could join us today. And on behalf of Intuitive Surgical, thank you for taking time out of your busy schedules to be here. We know how hard nurses work, and we truly appreciate your interest in exploring how robotics is shaping the future of nursing and patient care. Today's session is all about innovation, and more importantly, the incredible people driving it forward. We're excited to introduce to you two outstanding nurses from St. Joseph's Healthcare Hamilton, Maria Pacaldo and Michele Dodds, who both have extensive experience on Da Vinci surgical systems. Their unique perspectives and real-world experiences will offer valuable insights into how our technology and nursing can come together to improve patient outcomes, enhance team efficiency, and collaboration. After the presentation, Maria and Michelle will host a live Q&A, so please feel free to drop your questions in the chat or jot them down to ask at the end. We'd love to hear from you. With that, I'm delighted to hand it over to our speakers, Maria and Michelle. Please join me in giving them a warm welcome. And on behalf of everyone on our team at Intuitive Surgical Canada, we want to express our heartfelt gratitude for the incredible work you do for patients every single day. Thank you and enjoy the presentation.
All right, so our presentation for today is going to be about running a successful robotics program in Ontario. This is just our agenda and what we're going to touch upon. So we're going to do a brief introduction of ourselves, talk about our facility, St. Joseph's Healthcare Hamilton, the robotic coordinator role, the nursing role in a robotic room, our successes from our recent expansion, and preparation of a new launch, and tips on running an efficient robotic program, and any common myths about the robot room. So just a little bit about myself. I did my BScN at McMaster University and my peri-op certificate at Mohawk College in Hamilton. I have about 10 years of nursing experience, and 5 years of it is in the operating room. And I'm the specialty resource nurse for cardiovascular, thoracic, and robotics at St. Joseph's Hospital. And a little fun fact is that I started in the operating room during the COVID pandemic. So it's a different landscape to what it was before that and to now. My interests have always been in cardiac thoracic, even when I was in nursing school and after moving to the operating room, which really provided me with that great opportunity to explore that interest. My first robotics experience was working with Dr. Hannah on one of his segmentectomy cases. I was able to see the Firefly technology in action and how it refines the surgical technique of identifying structures of the lung segment that they will be resecting, which was a very cool experience to see. It can be intimidating learning additional skills that it pertains to the Da Vinci robot, but a good foundation of working in open thoracic cases and VATS cases really prepared me for any unexpected situation that may arise during the case. And overall, it was a wonderful and supportive environment that made my initial experience with the robot memorable.
Good evening, everyone. I'm Michele Dodds, and I'm a core member of the urology service at the St. Joseph's Hamilton operating room. I worked many years on a thoracic surgical step-down unit and also a hemodialysis unit. I spent 3 years as a travel nurse in the US, California, before transitioning to the operating room in 2008. Currently, I work in the urology service and I'm part of the robotics team. I work extensively with the Da Vinci surgical system since 2014 and completed the robotics coordinator course in 2024. Since completing that course, I've also received multiple certificates from Intuitive via the AORN regarding operationalizing robotics in the acute care setting. I have a wealth of different experiences to draw from, and I'm an advocate for change and education at any stage of one's nursing career. It's very exciting using advanced technology and learning new ways to enhance patient care and contribute to positive clinical outcomes. I'll just give a short description of St. Joe's Healthcare in Hamilton. Our hospital employs more than 5,000 staff and has approximately 1,000 volunteers. It has highly sought-after surgical programs for residents and fellows to achieve high levels of education and experience. St. Joe's Healthcare in Hamilton is known for excellence in respiratory care, mental health and addictions, kidney and urinary care, women's and infants care, surgical services, and education and research. So I'll give you a little overview of this Da Vinci Xi system. So pictured here are the components of the Da Vinci Xi surgical system. Firstly, we have the patient cart, where robotic instruments are inserted. Key features are an adjustable boom, universal arms, and a helm touchpad. In the center, we have the vision cart, which is the brain or control center of the system. Key features are a touchscreen monitor, electrosurgical unit, and an endoscope controller. And then on the right, we have the surgeon console, and its key features are a 3D viewer, hand controls, and ergonomic design. St. Joe's also has a simulator that allows practice and training to learners wishing to improve skills and mastery of movements. We also possess a second console that can be used during cases for residents to hone their skills under direct supervision of the staff surgeon.
So just a little bit of a background on our robotic program at St. Joseph's Healthcare. The first robot system that St. Joe's procured was the Da Vinci SI back in 2012. And the first XI system came on board in 2020 with the addition of a second XI system and simulator in 2024. The Da Vinci robot was first introduced in 2012 through generous donations from the community. Our foundation really engages the community donation through individual robotic tours featuring the robot. Our first prostatectomy and lobectomy were done robotically in early 2012 at St. Joe's, and we are recognized as a center of excellence in robotics and are nationally recognized as the leading robotic center in neurology. We've performed over 5,100 cases robotically since its introduction in 2012, and the first robotic cystectomy was performed back in 2020, and the first robotic esophagectomy was performed in 2022. So this is the slide that just outlines our hospital's amount of robotic procedures to date. Most of our robotic cases are urology cases and thoracic. So to date, we've done 5,600 cases, and urology does the majority of them. So we've done quite a bit of prostatectomy, cystectomy, and the newly onboarded service of partial nephrectomy. And in thoracic, we do quite a bit of lung resection, both lobectomies and segmentectomies, and esophagectomy. And our head and neck service does some tonsils and tongue resection.
This slide will show a list of robotic procedures performed to date at St. Joseph's Healthcare in Hamilton. The robot is used almost every weekday, often with 2 robotic rooms running simultaneously. Looking to the future, a third robot will be necessary due to future onboarding of general surgery and gynecology services. and the increased demand for a robotic block time to complete cases and increase proficiency of surgeons and staff.
So now we're going to talk about the key roles in a successful robotics program. So who are the key members in contributing to this successful program? The first one would be the most important, which would be the patients who have consented to these procedure approach. And without them, we wouldn't be able to see this technology go further. Then we have our surgeons. So it would primarily be Dr. Shagan and Dr. Hannah. Their surgical expertise in the Da Vinci helps expand the knowledge and use of the robot, which leads to positive outcomes for patient care. And then we have our robotic coordinator, who is a key member that connects all the members of this team in creating a cohesive and successful program. Then we have our nurses. So without our robotically trained nurses, a robotic room wouldn't function as it is. And then we have our management, booking office, NGR, materials coordinator, and our OR educator, who all play a crucial role in ensuring that the service is efficient and successful in order to meet the needs of our community. We will mostly focus on the role of the robotics coordinator and the nursing role in a robotic room in this presentation in order to give you a highlight of these key players in creating that successful environment for the robotics program to thrive and continue to expand. Now we're going to talk about the robotic coordinator role. So they are the primary contact person that onboards new surgeons and nurses into the program. They help coordinate training new nurses in collaboration with the OR educator in ensuring that the new staff has completed their online learning modules and that they are adequately rotated in different services for proficiency. Next is they facilitate new robotic instrument requests from surgeons to the materials coordinator. They collaborate with specialty resource nurses of each service in designing pick tickets to increase efficiency of onboarding new surgeons. They provide resource support to new nurses in the robotic room and any additional training or teaching on use and care of instruments, whether that's to nurses or the MGR department. And as part of being a liaison, the role in onboarding a new surgeon is critical as they help prepare and create the pick tickets for robotic cases. They ensure appropriate booking of cases, coordinate staffing needs for robotic rooms, and they also have access to the customer support portal for instrument and case data tracking. And of course, they participate in the ongoing development of the program.
So this slide provides an overview of how a typical case would look like in a robotic room. Our robotic rooms are staffed with 2 circulating RNs and 1 RPN scrub nurse, which helps divide the tasks during the initial room setup for the first case. Now, this slide looks like a lot of information, but most of these tasks are things we already do in a typical day without a robot. Only the highlighted parts of the slide are the tasks added on in a robotic room setup. The biggest task happens during the setup portion, which is your first case of the day, which includes the room layout, such as the location of your vision cart, patient cart, and consoles, and also connecting the robotic cords to each component. These tasks are completed quickly with practice, and the more you do it, the easier it gets. Once initial setup is completed, responsibilities during the case do not require much time. So when onboarding a new surgeon to the robotics program, we must collaborate with the new surgeon on preference tickets with focus on specific instruments required for their particular robotic procedure. Additional robotic instruments are requested and created into instrument sets. We must plan room setup and patient setup for docking the robot. New surgeons train at a robotics center prior to their first case at St. Joseph's Hospital, and the surgeon is also proctored during their first few cases by an experienced robotic surgeon who provides support and guidance. Appropriate nursing staff is assigned to the robotic room to provide expertise and support with troubleshooting and to ensure efficiency. The robotic coordinator works with the new surgeon to optimize preferences as they gain more experience working with the Da Vinci robot.
So now we're going to talk about setting up for success before a new surgeon launch. So it's imperative that collaboration occurs with a new surgeon, particularly on building their preference ticket for their robotic case. Sometimes that includes using another surgeon's robotic preference ticket as a foundation and then making it their own. And this role is often covered by the robotic coordinator in collaboration with a service-specific specialty resources to really capture the needs of the case preference ticket. And then optimal staffing, ensuring that there's a robust group of nurses who are experienced in that particular service, for example, thoracic or urology, are assigned in the room of the new surgeon if possible. This is to ensure that familiarity with instruments, surgeon preference, and collaboration leads to positive outcomes. The team dynamic is preserved, which can lead to decreased stress, increased motivation, and morale of staff. Then there's the inventory. Instrument and equipment requests are completed and built into their preference ticket prior to launch, and making sure that supply levels are optimal and backup instruments are available. And then there's the OR block. So there's adequate nursing staff are assigned to the robotic room in the event a case goes over the time allotted, and ensuring that extra time is allotted for the case so that there's no pressure for the surgeon to rush. Okay, so now we're going to talk about the integrated technologies with the Da Vinci. Great. So we'll see the Firefly, Tile Pro, Vessel Sealer Extend, the Sureform Stapler, and the Irby Generator. And we're going to have a photo of each of that. So the first one is the Firefly technology. So this is what we mostly see during thoracic cases. So it's an endoscope technology that lets the surgeon see fluorescent dye when injected intravenously. This helps with identifying particular landmarks, such as vessels and segments of vessel resected portions of the lung. This allows the thoracic surgeon to pinpoint the segment where the tumor is located and confirm if there are additional vessels they would need to resect for an appropriate margin of the tumor. That's the Tile Pro.
Next, we have the Tile Pro. With this technology, we are able to view auxiliary images independent of surgical images. For example, when doing partial nephrectomies, an ultrasound machine is connected to the vision cart, enabling surgeon and staff to see ultrasound visuals of vessels and blood flow to the tissue surrounding the tumor. This information guides them as to where to place clamps before beginning to excise the tumor.
And this one is the Vessel Sealer Extend. We mostly use them in esophagectomies for sealing vessels supplying the stomach, but they also use it during lung resections for vessels that are very small and hard to get around with the Sureform stapler. It is an advanced sealer that seals and cuts up to 7 millimeters diameter in any tissue bundles that it fits into its jaw. And next is the Sureform stapler. At our facility, we have both the 45 curved tip and the 45 straight. It's a stapling technology that provides feedback to the surgeon as they use it. So it puts the computer between the surgeon and the stapler to ensure optimal staple line formation by pausing for compression as it fires and providing that feedback to the surgeon.
And next, we have the Irby Generator. It is an electrosurgical unit integrated with the system. It indicates the location of installed energy instruments and displays energy tissue effect settings at the surgeon console. It has monopolar and bipolar capabilities and can be controlled by the surgeon on the console or by a circulator using the generator. I'll briefly introduce some members of the core urology and robotics team. On the left, we have Elisa Bolignon. She is currently the specialty resource nurse for the urology service and robotics. Next to her is Dr. Bobby Shagan, who's the chief of surgery at St. Joe's. He performed the first robotic prostatectomy in 2012 on the Da Vinci SI, and he is instrumental in the advancement of the robotics program. Next is me, Michele Dodds, a longtime member of the urology and robotics team and a resource person for others in the OR. And then we have Pam Courier, who's also a longstanding member of the urology and robotics team, and she's an excellent teacher and trainer to all. We all strive for efficiency and have a lot of fun working together, which makes the days go by fast. So I'd like to share some successes from the recent urology expansion. First of all, surgeons are able to do much more complex cases in less time. The range of instrument dexterity is better than traditional laparoscopic instruments. It's like you get a whole wrist movement instead of just the tip of an instrument. We have three-dimensional versus two-dimensional images equaling increased depth perception. We're experiencing decreased case times, and there's less reliance on bedside assistance with the use of a fourth robotic arm, meaning less people are scrubbed in during the surgery. This photo shows the 3 new urologist onboards performing partial nephrectomies. So from left to right, we have Dr. Yambo Guo, who completed his first partial in December of 2024. In the middle, we have Dr. Shahid Lambe. He's the head of the urology service at St. Joe's, and he completed his first partial in January of this year. And then we have Dr. Rahul Bansal, who completed the very first partial at St. Joe's in November of 2024. So I'd like to go over some positive clinical outcomes since expanding. Complex cases can be completed robotically as opposed to an open laparotomy. We've had no conversions thus far from robotic-assisted cases to open laparotomy in any of the partial nephrectomy robotic cases. Surgeons are able to remove a portion of the kidney instead of performing a radical nephrectomy. And there have been decreased use of drains in shorter hospital stays for some of the surgeons' patients, equaling potential same-day discharge. Also, we have decreased warm ischemia times, which preserve function in the remaining portion of the kidney.
So now we're going to talk about the recent thoracic expansion. And we have a picture of Dr. Cho here. In regards to our thoracic department, so 4 out of our 5 surgeons are now robotically trained. It's a very unique fellowship program where most of our fellows are able to gain experience in the Da Vinci during their fellowship. This experience has helped them become leaders in expansion and change at their own facility after they graduate. And we'll talk about Dr. Cho. So Dr. Cho is actually one of our newest surgeons to be trained in the Da Vinci. She was a previous fellow and had a chance to work in the robot and be behind the console during her fellowship. I actually helped during her onboarding process, from designing her own ticket and also providing support during her cases when it comes to troubleshooting the robotic stapler and other instruments. The feedback that I received from her was quite positive, and she continues to be enthusiastic about learning the Da Vinci. So at our facility, robotic-assisted thoracic surgery is actually not funded by OHIP and are completely funded through research and philanthropy. And with the increase in robotic cases that our thoracic department has done, will ultimately result in a more proficient surgeon, as evidenced by Dr. Cho's experience. So the more they do, the better they get. And then we're going to talk about some clinical outcomes from that thoracic expansion. So these are some of the outcomes that surgeons see in the inpatient units post-op, and also supported by research that they have done during the inception of robotic-assisted thoracoscopic surgery at St. Joe's. So there's an increase in segmental resections, which is good for the patient because that means there's less lung tissue is removed compared to a traditional lobectomy to remove a lung tumor. They have a shorter length of stay compared to thoracotomy because of the smaller incisions, which is about 8mm ports of the robot ports they use, which also means that there's less pain with those smaller incisions. Robotic-assisted lung resection leads to less conversion to thoracotomy compared to the traditional video-assisted thoracoscopic surgery, and a shorter case time with robotic-assisted compared to video-assisted among bariatric patients with the help of that 360-degree articulation of the robotic instrument tip, which helps to get around those difficult structures in bariatric patients that the traditional VATS instrument would not be able to get around.
So some tips to running an efficient robotic program would be to provide adequate training to nursing staff in the robotic rooms. So train nurses already working in that particular service to utilize their experience with open cases in the event a robotic case needs to convert to open. Recruit eager nurses to train in the robotics program and provide support along the way. Provide reference materials showing different room setups for different procedures. Optimize the surgeon's preference ticket in order to eliminate instruments or supplies not needed, thus decreasing setup times. Optimize instrument sets to better capture what's needed during the case. Checking case carts prior to the procedure to decrease delay during setup, which we do anyway with or without a robotic case. The specialty resource nurses for each service should be extensively involved in planning and executing case management. And we should strive to optimize the robotic block by advocating for 2 cases per day and sharing open robotic blocks with interested surgeons.
Okay, so now we're gonna talk about some common myths around the robot room that we heard during the early days of the robotic program and even now. This is especially true when we train new nurses in robotics. And we will talk about each and also debunk some of those myths and give you some tips on how to encourage more nurses to learning about the Da Vinci. So the first myth and the biggest of all is that driving the robot is scary and intimidating. I mean, I certainly felt that when I started. They're letting you drive $1 million equipment, all while avoiding monitors, surgeons, and keeping it sterile all at the same time. Talk about intimidating. And what helped ease the anxiety is having a supportive group of experienced nurses in robotics, intuitive reps, and also surgeons. Because at the end of the day, everyone started somewhere, and the robot is not as fragile as you think, but we still do need to take care of it because it is $1 million equipment. And then there's the big case setup with lots of instruments. It's actually just an addition of 4 robotic instruments, a scoop, and a trocar and cannula. So it's about 3 instrument sets. And the way you would set up laparoscopic surgery would be very similar, and sometimes even less instruments on the table. Then there's a mandatory overtime. This goes back to having a well-involved robotic coordinator when it comes to staffing. When there's enough robotic nurses trained and booking times are correct, then it minimizes the need for mandatory overtime. And it's difficult to learn. The interface of the robot is very user-friendly and easy to figure out. And you also have the support of a 24/7 support line to help troubleshoot during a case in real time. And we have knowledgeable, intuitive reps for support during cases. They do visit sites as well and provide support during cases.
So during this presentation, we've talked about successes and positive clinical outcomes, how exciting the program is, debunking some myths about the robotic program, positive steps toward the future, and focused on providing highly advanced quality patient care. So in summary, we've touched on ideas, observations, and information we've acquired through our experiences working within the robotics program at St. Joseph's Hospital in Hamilton. Learning about the Da Vinci robot is an exciting endeavor as a nurse, and being part of the continuous advancement and the way we care for our patients is very rewarding. It is the future of minimal access surgery, and it is inspiring that operating room nurses have such a key role in its delivery. We hope that this presentation was insightful and educational and able to alleviate stress and anxiety levels for those of you preparing to launch an exciting new robotics program. Best of luck for the future. Thank you very much.
Okay, so now we're going to move on to the Q&A portion of the webinar. So feel free to send your questions and we will answer them to the best of our ability.
Well, that was incredible. Great job, Maria and Michelle. Thank you so much for sharing all of your experiences. I am intrigued by what is the art of the possibility in terms of other types of procedures as things continue to evolve. There are a couple of questions here, so perhaps we can start with the Q&A. The first question is, are your robotic cases scheduled into a robotic block, or do the cases count towards the service blocks?
Do you want to flip this one?
Yeah. So for thoracic, we have a separate robotic block, but we have actually recently expanded and we used one of our service blocks and converted that into a robotic block. So we have an extra, the first and the last week of the month is a block for robot.
In the urology service, we generally run at least 2 robotic cases all the time in a robotic room.
Okay. How many robotic cases would you do in a day, like in either of the 2 rooms? I'm just curious, like radical prostatectomies versus thoracic. I guess it depends on the type of case, but the numbers for urology are quite high. So how many would they do in the urology room?
Traditionally, we did 2 cases, and just recently, Dr. Shagan and Dr. Matsumoto have started to do 3 cases per day when they have late block time.
Oh, that's excellent. So
Yeah.
that's like a 10-hour room then. Yeah. Okay.
Yes.
Excellent. Great. Okay. Next question we have is, do you capture extra time during robotic cases? Do you capture extra times during robotic cases? So presumably, what time do you maybe start the robot versus patient in room? I think that's what they're asking.
I think I can speak for thoracic service. So when I actually look at the setup time compared to a regular non-robotic thoracic day, it is actually about the same amount of setup time. So we're not actually adding in terms of blocks. And as our surgeons get better at what they do, they are actually taking less time, like surgical incision time from start to finish, compared to when they just are starting onto the program.
Fantastic.
For the urology service, there is no extra time captured for anesthesia or anything like that. The patient comes in at the same time they normally would, with or without a robot.
Okay, thank you. I'm presuming that you maybe have like a block room for any of your arterial lines, et cetera, before transfer to the OR, or does that save you maybe a bit of time? Yeah, okay, that makes sense.
Not so much for urology. I think thoracics requires much more blocking than we do for prostates or partials. We do art lines and second IVs, but we've done so many now. We're very efficient that it takes no extra time for nursing to set up a case for robotics.
Excellent. Okay, thank you for that. And Martha has a question. If thoracic robotic surgery is not funded through OHIP, how is it funded at your center?
So ours is actually funded through research and philanthropy. So the inception of like robotic assisted thoracic surgery at St. Joe's first started through research. So a lot of our instruments, all of our supplies is all funded through research. So they're constantly doing research studies on whether robotic surgery is leads to shorter length of stay, more positive outcomes for patients. So, and also philanthropy, which how we were able to fund 2 robots in our hospital.
And now maybe you're getting a third, which is very exciting for the Hamilton
Mhm.
area and the patients that come for care there. We have another question. Do you have pictures in your preference cards? Are you able to load those into Epic for your setup at all?
Yes. Yes, which
Oh,
is very helpful for new staff that are trying to learn into setting up the robot. And we also actually have a binder in each of our robotic room, and it tells you what the room, like the bed layout looks like, the room layout with where each console, the patient card, vision card is located, depending on the type of surgery that we're doing.
I love that, just to have that standardized setup for people to learn and become proficient. That's really important. Norma has a question. How long is your nurse training program?
Well, the module takes about a day or two, depending on how, I guess, how dedicated the nurse is in completing those modules. But once their modules are completed, they go into hands-on training, which is about 2 hours, with just actually learning about each component of the robot, learning how to drape it, learning how to drive the robot, and how to plug in any of the equipment. And then they each get rotated in each of the services that does robotics. Normally, it takes about 2 days per service, and then depending on the level of comfort of that nurse, whether they require additional days in that particular service. But otherwise, once they've done their 2 in that particular service, then they are independent.
And they can, of course, request more time if they don't feel comfortable.
Mhm.
And that's everybody on staff. There's the expectation that they'll develop that competency over time.
Yes, and also when we try to staff the robot rooms, you always try to staff somebody who is experienced in that particular service to help better support the new learners in that case.
That's wonderful. It's a great model for training for sure. It's obviously working well for you. We have another question. Are the open instruments ready and counted or available?
So I can speak for thoracic. So we have a lot of instruments when we do open cases. We have actually optimized our set where we have a specific instrument set that doesn't have all the retractors, like the chest retractors that we will need for open cases. So it's very streamlined. And then our case cart comes with all these bins full of those additional open items in the event that we do have to open during the case.
That makes a lot of sense. That's great. And I remember during the talk that there were no incidents of conversion. So at this point, I'm feeling like the urology cases are very predictable. Would that be true in terms of?
Yes.
Yeah, thank you.
Yes, our case cards don't come up with open instrument like book Walters and things like that. They don't even come up on our case cards.
Okay, great.
We do have an emergency cart in our sterile core should we need something in a hurry, but generally our case cards just come up with our basic robotic instruments that we need.
Excellent. And we have another question. As urology patients are in steep Trendelenburg, what positioning devices do you use? Great question.
Yes. Well, we have, first of all, the Megadyne gel pad, which they stick to, which is secured to the bed. And then also the foam ulnar pads, we put them, 4 of them in like a cross your heart across the chest. And then they're securely taped with 2-inch hockey tape many times in different directions to keep them from sliding. And it's worked wonderfully so far.
So you haven't needed to have a huggy back or anything like that. That's interesting.
Yeah, no. The anesthesiologists were having difficulty accessing art lines and things like that, the huggy back. So with the arms tucked and the cross your heart taping, seems to work for everyone involved.
Okay, food for thought. And then one more question regarding equipment. Do you have a specialized OR table to use with a robot, or do you use a regular back table, etc.?
We use a regular table.
Wow.
Regular table. Yeah.
Yeah.
Low tech table for high tech. Yeah, amazingly high tech. It's amazing what the art of the possible is here. Excellent. Now that's it for Q&A. So let's see if there's anything in the chat. So I'm going to just flip out for 1 second to see what I can find. Bear with me as I navigate that.
Just to add on to that table question, our tables are adjustable too. As some cases we go over the patient's foot, and some cases our table is off to the side. So they're adjustable.
Okay, you have the ability to raise or lower them accordingly.
Yeah,
so back table, but not necessarily an overbed, so to speak, right?
Yeah, it can be either one. Yes.
Oh, excellent. Okay. I think we answered this question, Natalie, but Natalia, how long does training take for an OR nurse to learn robotics?
I guess to be proficient at it, I mean, the more you can get in there, the easier it gets. But generally, we assign about 3 days to learn the basics of what we do before you're on your own.
Generally, if you have already worked in that particular service, like you experience in open cases or other like traditional laparoscopic cases, and then moving on to a robotic cases, it is so streamlined and so quick to learn after that, that it would take you less than somebody who has not experienced any of that.
I'm just wondering, in terms of obviously thoracic and urology are different procedures, but in terms of transferability with using the Da Vinci, there's some element of some foundations there that would transfer over. Would you agree with that? So if you've learned how to use it in urology, for example, your proficiency in all likelihood for thoracic should be much faster. Yeah, excellent. And then the final question from, I think it's Suki, I hope I've said that correctly. What type of procurement methods did St. Joe's use to acquire the Da Vinci's? And then there's more to say, capital purchase or lease option. What was the reasoning for choosing the method that you went with for procurement?
I think the initial, correct me if I'm wrong, Michelle, but the initial XI that was purchased was through capital.
Yes.
And then the second one is through a lease option.
Right. And if we acquire a third, it would probably be through a lease option as well, per use.
Excellent. I'm thinking about upgrades in terms of software, etc. You must have that planned, or you're not using it 24/7, so there's downtime at which time you could have that maintenance and upgrading completed.
Yes, the intuitive engineers are fantastic, and they'll come in after end of day, after the cases are finished. Sorry, it's my automatic cat feeder. They'll come in at the end of the day when we're not using it anymore and do any repairs that need to be done, or updates or upgrades. Yes.
We love our vendors.
They're very good with that. Yes.
Very good. Very good. I had another question in terms of the instruments that are used with the Da Vinci. We don't have a Da Vinci in the organization that I work for, and I'm curious about what those look like, and are they reusable, reposable, the instruments that are used with the Da Vinci?
Do you want to take this one, Maria?
Yeah,
They're
sure. Yeah.
Okay.
So each instrument has a set number of lives that can be used. So whenever we in a case, at the end of the case, we actually look at the vision cut, and then we can see how many lives that instrument still has. And if it's end of life, then we will replace it, and it will get reprocessed again in pouch.
Well, that's ideal in terms of always having a precise instrument with minimal invasive. I think it's the evolution of minimal invasive, to your earlier comment, is going towards robots and all sorts of surgical specialties. In terms of moving forward into more approaches, is there a vision for moving in more services like the gynae piece? I'm in a gynae-onc center, wondering what that would look like, because that would be so wonderful to minimize the blood loss, keeping patients warm, all the things that we're sort of battling every day with those complex cases. I saw the hysterectomy. Is this being used anywhere? Maybe not at St. Joe's, and maybe this is a question for Samantha, but in terms of complex oncology procedures, are any centers using it for, I mean, obviously prostatectomy is oncology, but gynecology, general surgery, any other applications that you're able to share with us?
Sam, is it okay if I take this one?
Yes, absolutely, Nev.
Okay, perfect. There's actually a huge role for Da Vinci in both gynae oncology and gynae benign, and we're starting to see growth of gynae benign, especially in Ontario right now. And a hysterectomy is an obvious one with both lymph node dissection for cancer and even without for benign. But the other space where it's growing a lot is myomectomy and endometriosis resection. The surgeons can get really, really close to the tissue and see more lesions with a Da Vinci scope than they can with even a 2D scope. So they're able to do a lot more resection for endometriosis, and that's where we're seeing a lot of growth in Ontario.
That's really exciting, given the cohort of patients that we're speaking of. And do you think that it'll become standard of care? I mean, if this is the way the trend, minimal invasive, better for patient outcomes in terms of shorter hospital stays, home the next day, if not the same day. What's sort of the projections there? Is there any business plan around that? Just curious.
I personally absolutely hope so. And I think we will eventually get to that point where, especially with women's health, always kind of being at the back end of the top care. I think we'll definitely get there, and Da Vinci is a big component in that.
Well, I'm very excited to hear more and to watch as things evolve. Thank you for that detail. Really appreciate it. We do have another question, anonymous, otherwise I'd say who, but regarding equipment, do you have a specialized OR table or use with the robot, or do you use a regular OR table or bed?
Regular bed.
Yep, regular bed, regular adjustable height table.
Yeah.
And if I could just add, there is a bed that is compatible. It's made by Hillrom, I believe, that is compatible with the Da Vinci. So if the surgeon needs to do changes intraoperatively, they can. Mostly general surgery uses that, but with at St. Joe's, they use the regular OR table.
Yeah, because with a regular OR table, you cannot move the bed at all once the robot is docked. But there is a bed that integrates with the system that can be moved if you have that table.
Fascinating. That's fascinating. I'm thinking about bariatric patients as well. Like there was mention of bariatric procedures for the esophagectomies, I believe. But in terms of bariatric procedures, is that niche for Da Vinci as well, or just modified in terms of instruments, longer instruments, etc.?
When it comes to thoracic cases with bariatric patients, there's actually not much of a change in instruments. We keep the same instruments, and the beauty of the instruments of the Da Vinci is that it articulates 360, so it can really get around those tough areas where the muscle, where the trocar is put, and the intercostal muscles, like it actually prevents a surgeon from putting a vast instrument through there and manipulating it in a way to actually grasp what it is that they need to grasp with a traditional video assisted surgery. So with the Da Vinci, they don't need to worry about that because the reach and the articulation of the instrument helps with that.
There's also a patient clearance button that you can use that will actually extend the reach as well of the instrument, the robotic instrument.
Well,
And
Mhm.
I was going to add, and robotic bariatrics is something that's new to Canada, and there's only a couple of programs, but that is another space where they're seeing with those really very high obesity patients, where they're seeing a lot of value because it's less torque and tension on the muscle wall for the patient.
Well, I just, there are so many things popping in my head in terms of what could the future hold. This has been a really great review. I think definitely Maria and Michelle, I think you're ready to take this beyond our group. You've done a fantastic job tonight presenting. So kudos to both of you, and certainly to Samantha and the rest of the team at Intuitive. We really cannot thank you enough for the support. It's from this kind of support where nurses across the province can come together and really learn and become more educated, if not more interested in the types of technologies available for patient care. So thank you very sincerely for your support and sharing your knowledge with us tonight. Any final comments that you'd like to say?
No,
Thank you for
everyone for attending, and also to Maria and Michelle for doing such an incredible job. Thank you all. We appreciate you.
I 100% believe in this technology, and I think it's fantastic and amazing for patient outcomes.
I agree. It's a great opportunity as a nurse to advance your knowledge. And yeah, everyone should train and be interested.
Yes.
Yes, I mean, you've piqued my
Exciting.
interest. I think I might reach out to Jill, your educator, being in the Hamilton area, and maybe come and see. And I really liked how you set up the task list, and how you highlighted that you're really only adding a few things, and it's a little less overwhelming for staff. So I'll definitely be in touch. Really excellent job tonight. So well deserved. Congratulations, and we'll be in touch soon. Thank you so very much.
Thank you, everyone.
Thank you
Good
very much.
night.
Good night.
Thanks.